Dr. Joseph.
Right.
Do you have the slide? Do you have a slide?
We have it there. You have my slides, right?
Hold on. It takes a few seconds.
It's all right.
They're warming it up. You have one of these?
I don't think so.
Yeah, I also wanted I was looking at her.
Wait, guys, please come back soon.
You're working?
Can you hear me?
Okay, we start. Good evening, everybody. Why chronic disease prevention and management? My name is Dr. Halasa. Dr. Joseph James is my partner. We have a clinic in Hollywood, and it's all about managing chronic diseases, and we label it as chronic disease prevention and management. And the reason why, because I think the system, they don't want you to be labeled yourself with how you're treating the diseases, because when you call yourself integrative, regenerative, the system here, they feel that you're going to take away the big pharma products and you're not going to use it. So I think that's the reason that we call ourselves, or they are okay with calling ourselves with how we treat, what we are treating, not how we treat the diseases. And so you can call yourself neurologist, cardiologist, but don't call yourself regenerative or holistic. That's how they are. Because it will prevent them from selling their big pharma, and then you are directing what you're going to use, and you're going to be banning the product. So that's the reason of the system wants us to call ourselves with what we are treating. And what we are treating is chronic diseases across all medical specialties. And American Medical Association, they have a group, it's called CDPM group, and they come up with a way of redefining history physical exam to be more comprehensive, to include all the system. It's the same concept of integrative medicine, but they don't want to call themselves integrative medicine, they call themselves chronic disease prevention and management, CDPM. You can search that in Google with American Medical Association. But what is chronic disease prevention and management for us as our team? It is actually managing chronic diseases by modulating the immune, metabolic, regenerative, and redox. So there's 4 pillars when we are managing chronic disease. And we heard that before, that they said acute system, or the way that we treat acute diseases, cannot be applied in managing chronic diseases. And yes, and that's why we fail in managing chronic diseases. But how we manage chronic diseases? What is the parameters or the pillars that we can use to manage chronic diseases? Is redox, metabolic, immune, regenerative. And as long as you are able to modulate those 4 pillars, then we can manage any chronic disease out there, whether it is cancer, infection, degenerative, autoimmune. And that's how we are now treating our patients with chronic diseases. When we take history and physical exam, and we are doing in our investigation in lab and treatment, we consider those 4 pillars in our management.
Can I add something? So I'm kind of like the interpreter for Dr. Halasa, and I think his work has been brilliant. The way I see this is that it provides a conceptual model in order, when you're dealing with somebody that they're complicated, especially now, the complications, the things that people are dealing with are just not straightforward, or the things that used to work aren't working as well today. And so there's all these different issues going on at the same time. I found this very valuable because this provided a framework to think about the patients, and also, am I addressing these 4 things: immune, redox, which is oxidative stress, which he understands very well, which I've learned the language of, metabolic, hormones, thyroid, testosterone, progesterone. You'll find we have a different way of seeing the hormones. And then getting those 3 optimal, including the bugs that we talked about, which would be under redox because of the toxins that they produce. Then the body, once all of those things are in balance, then the body will regenerate better with however you go about it. Say, for example, for exosomes.
Yeah, and that's how we use all these protocols that's all based on modulating, restoring the normality of those 4 pillars. And when we said metabolic, it includes everything, all the chemistry of your body, including 6 hormone, peptides, minerals, vitamins, everything. So that's the concept of chronic disease prevention and management as a new medical specialty, and we are developing diagnostic protocols, management based on those modulating and normalizing those parameters that we talked about. So let's go ahead and give an example. When we trying to manage multiple sclerosis, first of all, we need to define multiple sclerosis. Is it immune imbalance, metabolic, redox, or regenerative? It is an immune imbalance. And what happened in multiple sclerosis, that immune system is moving toward Th1 and Th17. Have you heard about immune polarization, Cyrex lab, right? And so now we define multiple sclerosis as first, it's immune imbalance. And when we manage it, we give all the drugs and supplements and peptides that helps to polarize the immune system from Th1, Th17 into Treg and Th2. So what will be an example of drugs and supplements and peptides and things that we do, including exosomes, that helps to inhibit the Th17 and Th1? Thymosin beta, let's give up. PVC 157, right? Methylene blue can be exosomes. What are the things that you think? Ivermectin can inhibit the Th17, but we don't really want to use it because it has a red flag on it. All right, what other things do you think?
Ozone,
Vitamin D,
antioxidants.
zinc, all of this helps to modulate and move the immune system to Th2 and Treg.
And I was just gonna mention, like you said ozone. And that is the way I see it, as far as seeing it as there's a pathogen underneath that's causing the inflammation or resulting in the immune system fighting something or over-fighting it, and then going after that pathogen in the safest way. And then the language that he's using, Th1, Th2, Th17, that's the language that I had to learn in order to know which peptide do you use here. The thymosin alpha behaves differently than thymosin beta, and then there's ARA290. And so you certainly, if you're dealing with something that, say, in multiple sclerosis is a Th1 dominant,
Th1, Th17, yes.
then you want to move it more to modulate it more towards Th2 as a way of reducing inflammation without necessarily using steroids.
Right, and you can use steroids. Steroids doesn't have all of them, the Th1, Th2, and Th17. But when you inhibit them all and aggressively, it may put the patient at risk of an infection and cancer. But sometimes we need to use it to stabilize the patients, especially when they flare up. But when we try to maintain it, we try to use less harsh products, peptides. There is some big pharma immune modulators that inhibit the Th17, which are not that aggressive as the immunoglobulins, or we call them the biologics. Then, is that enough? No. I think other metabolic, redox, regenerative needs to be modulated in order to optimize the whole body. Because if you have multiple sclerosis and you have leaky gut, or you have mycosis, you have fungus infection, Lyme disease, all these are free radical generators. And those free radical generators can irritate the immune system and cause more inflammation. So when we manage multiple sclerosis, it's not just enough to modulate the immune system with cortisone and all the immune modulators that we talked about. We also need to screen all the free radical generators, whether it's coming from leaky gut, so you need to fix that. If you have a patient with Lyme disease, you need to be fixed that. If you have low 6 hormone, you need to normalize that, because 6 hormone itself, especially progesterone, it definitely helps, works like cortisone, but it's different from cortisone. What's the difference? 6 hormone is regenerative and anti-inflammatory. Cortisone, it's anti-inflammatory but degenerative. And the reason why we age, and that's something when I take to another topic. The age, because when we reach age of 15, what would happen? The main reason why we age is the 6 hormone drops, and then your cortisone takes over. So before 50, we are more of 6 hormone dominant, right? And then after 50, we switch into cortisone dominancy. And cortisone goes what? Yes, it takes care of the inflammation, which is good. That also 6 hormone does it. But what's the difference here between pre-50 and post-50?
Catabolic.
Cortisone is
Catabolic.
degenerative.
Catabolic.
Catabolic is degenerative. It goes atrophy, degeneration, aging, white of the hair, shrinking of the skin, right? Degenerate your body. While 6 hormone goes what? Regenerative. So in order to prevent aging, what we need to do? We need to stop that switch, and we need to restore the 6 hormone. What's the best way of restoring 6 hormone? Giving testosterone and estrogen, giving progesterone. What will be the best?
Exercise and sex.
What do you give?
Exercise and sex.
Exercise is 6, but that would be not enough because the problem is we have cholesterol. Either they move either to 6 hormone or cortisone. Before 50, it moves a lot to 6 hormone, less to cortisone. After 50, we move more to cortisone. That's why we age. So what we need to give those patients?
I can help out.
We give progesterone. Progesterone will feed the whole 6 hormone because after cholesterol is what? Progesterone. And then
Pregnenolone actually.
pregnenolone, yes, and then progesterone. But I think it's better to do progesterone because there's something problems with age in making progesterone. And everybody above 50, we have progesterone deficiency, by the way. It's
Yeah,
fantastic.
let me put it into perspective, is that there's an epidemic of estrogen dominance, and we know that estrogens in particular are leading to more inflammation, leading to more overgrowth issues, including men's prostate glands. I never really understood it until now, or before, recently, that really men need progesterone too, because that's balancing out the estrogens. The estrogen is creating overgrowth, progesterone is needed for maturation, and if you have overgrowth without maturation, I guess somebody referred to it like a toddler running around, like just doing whatever, acting wild and out of control. And so the progesterone concept was a big deal, not to go too deep into that, but that's an example of metabolic
Right.
is being addressed.
So we need to fix.
But Antimmune,
Right.
and say in the context of multiple sclerosis, say if you have a nasal spray to deliver the progesterone directly to the brain, then it's anti-inflammatory.
And it inhibits the TH17 and TH1.
Yeah.
Naturally, instead of cortisone, right? And doing that, right, you can help in managing multiple sclerosis. So it's not just enough to do immune modulation. We need to restore the metabolism of the body. When I say metabolism, not just the sugar and cholesterol, when I say metabolic, every chemistry in the body needs to be normalized.
For males,
For what? For males, yes, you
Yeah.
need progesterone for males.
Yeah.
What is progesterone? The head after cholesterol is progesterone, and then progesterone, it gives you testosterone. Testosterone convert to estrogen, right?
Yeah.
In female, you convert all your testosterone, most of testosterone to estrogen. We keep, us male, we don't convert them to estrogen, we keep them at testosterone, we just give little change to
That's how
testosterone.
your brain communicates through estrogen. So your testosterone has to convert to estrogen. to
Yes,
communicate
we
in the
will
brain.
convert, but not as much as you converting
No,
to the
yeah.
estrogen, right? And that's why you feminize and
But
wear
only
male.
estrogen to communicate with.
Right, that's right. But the problem with estrogen, it's feedback and inhibit the endogenous production of luteinizing hormone and follicle stimulating hormone. So what would happen when you give patient pellets of testosterone without anything else? And especially if they're a little bit obese. What do you do? Aromatization turns into what? Turn to estrogen. What exact estrogen? There's 3 forms of estrogen.
Estrone.
There's estrogens, there's estradiol, and there's what?
Estriol.
Estriol. Okay, let's see the difference. What's the difference between those 3?
Estriol is the feminine one, the Venus.
Right.
Estradiol is the anabolic. Your
Uh-huh.
estrone is Cancer.
That's right. But let's go ahead and say the exact function of those 3 and know exactly what's going on. Estriol is like progesterone. Estriol, it's anti-inflammatory and anti-proliferative, which is a good thing. Estrogens is the bad guy, is the culprit, is the problem. It's causing all the cancer. It's inflammatory and proliferative, right? Estradiol, something good.
Above the belt.
It is proliferative, but it's anti-inflammatory. You got my point? So, where's the bad guy is the estrogens. We don't want the testosterone to convert to estrogens. We don't want the estrogen to convert to estrogens. And not just that, estrogens is a culprit, and also it moves the cholesterol to make cortisones, and it causes the aging and inflammation. So if you have estrogens high in your body, what will happen? You will have high risk of prostate cancer, breast cancer, endometrial cancer, all the problems. So if you're doing sex hormone the wrong way, you're causing what? Metabolic syndrome, because you are pushing the whole thing into cortisone dominance again, right? Estrogens, it's promoting cortisol, and it leads to cancer. So how you stop that? Give them progesterone, because progesterone is considered as aromatase inhibitor. Okay, what other thing you give? Iodine. Iodine helps to prevent the conversion of estrogen to estrogens, and it moves it more to estriol. Okay? So what I will do to the patients,
And
I
plus,
give
there's,
them,
and plus there's an iodine deficiency.
right. So anybody
Severe.
above 50, what you gonna give them? Intranasal